So today we're going to talk about collecting outcomes for clinical care for tinnitus. We'll be talking about using standardized outcomes instruments. Specifically, I'll be talking about the tinnitus functional index, but these concepts apply to other standardized outcomes instruments or validated outcomes instruments, and about patient reports, just subjective reports of whether or not they feel like they're doing better than they were before. And we'll think about both of these things from the perspective of looking at a single individual and also looking at groups of people. So just to get a feel for who's in the room, although I know a lot of people in this room, and I don't think I can hear from the people at the other sites. Is anybody here providing care for tinnitus beyond hearing aids? All right. Surprise. And are there people in here regularly using tinnitus outcomes instruments like the TFI people? All right. And is anybody already using individual change scores to inform conversations with patients? Okay. I know too much about this room. I'm going to stop asking questions. I know the answers. All right. So these are some common reasons that clinicians collect patient outcomes data when they're providing care for tinnitus, documenting change following provision of care for tinnitus. Another reason is quality improvement. So looking at your mean data for all the people you're providing care for. So you can compare the outcomes of your program to what shows up in the literature. You can compare the outcomes of your program to your peers. And you can also compare it to yourself over time, figure out if you need to make changes, figure out if your changes are helpful. Another consideration is justifying the need for care and resource allocation. So if somebody is sniffing around your department looking for things to cut, for example, if we give an extreme example, it's really important to be able to show, if you're using outcomes instruments, you can show that your population of people need care for tinnitus, and you can also show that the work you're doing is changing quality of life for them, that it's meaningful. Today I'm mostly going to be talking about the tinnitus functional index. So this is an instrument that was developed by Mary Meikle and several other people at OHSU. So a little bit of a bias acknowledgement. This is an instrument that was developed by friends and family. This is the first instrument that was developed to be sensitive to change as a result of intervention, and they went about this in a really prospective, systematic, careful way. There are 25 items, 8 functional domains. This is an instrument that's pretty commonly used in research and in clinical settings. One thing to keep in mind is that the TFI, like all validated outcomes instruments for tinnitus, are vulnerable to influence from hearing problems. I'm going to talk a little bit more about that. So if you look at question number 5 on the TFI, it says, how easy was it for you to cope with tinnitus? So a really common thing is that people will blame hearing problems on tinnitus. They'll say that their tinnitus is a problem because they can't understand what people are saying. If you're looking at a question like how easy is it for you to cope with your tinnitus, it's easy to see that they might be putting down an answer that reflects that they're really having trouble coping with hearing loss. And we'll talk more about that later, but that's an important thing to keep in mind when you're interpreting outcomes. So let's talk a little bit about how much of a change on the TFI is considered to be meaningful. This is a really important question, and it's also a very hard question to answer. So meaning is very squishy. What's meaningful to one person is not meaningful to another. So we aren't ever going to be able to come up with one number that will always tell us if an intervention was meaningful to somebody or not. It's squishy and hard to measure, but we also can take a look at subjective reports of people who've received care to help us inform our interpretation of the meaning of the outcomes. So it's a little bit messy, but I think it's worthwhile to take a look at those. Let's talk a little bit about global assessment of change. So I've been talking about taking a look at people's subjective impressions of whether or not they're doing better after they've had some kind of intervention for tinnitus. Something that's starting to show up in the literature more often is a clinical global impression scale. And this isn't something we developed. It asks patients if their tinnitus after treatment, if they think about their tinnitus after treatment compared to before, would they say it's very much worse, minimally worse, no change, minimally improved, much improved, or very much improved? We use a similar question. It's not quite the same. The question we use is compared to before the study, my tinnitus now bothers me. The middle is the same, then it can say a little less, a lot less, a little more, somewhat more, a lot more. And I think there's an important distinction between these two things. So with the clinical global impression scale, you're really asking people if they think their tinnitus is worse, better, or the same. And you might be tapping into people's impressions of whether or not their tinnitus has become quieter as a result of the intervention you've provided or louder. When we were asking for subjective impressions, what we really wanted to know, we didn't want to tap into the loudness bit. We really wanted to tap into, is it bothering you more now than it was before? And so that's why our question is formed the way it was. Would you say compared to before the study, my tinnitus now bothers me the same, more, or less? And I'll point out that if you're using an instrument like the TFI, it's really important that you not change it. You really can't edit it, you can't take out questions, you can't add questions. But if you're trying to pair that with your patient's subjective impressions of whether or not they're doing better, it is okay to tweak that to kind of drill into what you specifically want to know. So there are a few important considerations when you're asking people if they feel like they're doing better or not. One of them is, are you going to administer this on paper, or are you going to ask them face to face? And the way we do it is we always do it on paper, and if possible, we leave the room while we're doing it. It can be hard for somebody who's been working with you for a long time to say, nah, I don't really think I'm doing any better than I was before. So we're just trying to make it as easy as possible for people to tell us what they really think. Also, it's great to just directly tell your patient you really want to know what they're thinking. I mean, the wording we use is we want to see how well our questionnaire captured your true feelings. The question below will help us understand what you're feeling. Those are the written instructions we give with this instrument. And then when I'm administering it, I'll say ahead of time, we really do want to know what you really think. That's what helps us to know what you really think. So with something like this, it's really important to do everything you can to make for sure people can tell you what people feel like they can tell you what they're really thinking. So let's talk a little bit more about the TFI and meaningful change. The authors of the TFI have given guidance on what's likely to be a meaningful change for an individual. And they went about it in a way that's pretty unique to the world of tinnitus outcomes instruments, but it's not unique to the world of trying to figure out meaning from outcomes instruments. When you're trying to look at assessing the meaningfulness of a change in an outcomes instruments, there are a lot of different approaches that can be used. There's definitely no gold standard. They're just kind of a collection of ways to become more informed about the outcomes you're getting. So Meikle et al., 2012, this is the original publication of the TFI. And the method they used, they kind of went two ways with paying attention to how much of a change on the TFI would be considered meaningful. And the first one I find to be particularly interesting. They took a look at the 1/2 standard deviation of the baseline score of the TFI for their entire population. And they did this with a very carefully chosen population. So they were very intentional about making for sure their population included a wide range of severity of a problem with tinnitus. They had people who barely had a problem with tinnitus, all the way to people who had a huge problem with tinnitus. And they were also careful to include people from a variety of different clinics that were offering a variety of different interventions. So this 1/2 standard deviation of a baseline score from an outcomes instrument, it's kind of like a rule of thumb. It's something that shows up pretty frequently in the psychology literature. And it really is only useful if you're looking at the entire population you would possibly be using this instrument on. And that's what they did. They were careful to make for sure that that's the population they were looking at. So they figured out the 1/2 standard deviation. And then, after they figured out the 1/2 standard deviation, they looked at the mean change on the TFI score for people who said, I'm doing just the same as I was before. And then they looked at the mean change on the TFI for people who said, I'm doing a little bit better, or minimally better, and moderately better. And they were kind of loosely connected. They weren't completely in different worlds. And so based on that information, they estimate that a reduction of 13 points on the TFI is meaningful for an individual. And that's where that number comes from. And I think it's important to understand the roots of where that number comes from. And it's intended to apply to anybody you'd use this instrument with, not just a kind of narrow population of people. Next, I'm going to give an example of something that happens a lot. So this is a paper by Starzinski from 2018. I'm just giving you one example, but they're not the only ones who've done this. It shows up a lot. So Starzinski, so the Meikle group was developing an instrument very carefully, paying attention to how much change might be meaningful. Starzinski was not developing an instrument. They were using an instrument to keep track of improvement in quality of life with tinnitus after people who had surgery for otosclerosis. There were 95 people. And then they paid attention to how much of a change on the TFI showed up before people were reporting that they felt better. And they estimated an 8.8 reduction or greater reflected a meaningful change for their population. So something you have to be really careful about is not plucking out a number like this from the literature and applying it to your population. This number, I think, has limited usefulness. It probably does help inform them about the meaning of their outcomes for their population, but I wouldn't apply it to anyone else. So we're going to camp out on this graph here for a little while. And my understanding is that I'm going to try doing pointing with this, with this pointer. To point to parts of the graph. Some people can only hear me and can't see me, so I'm going to do my best to explain this in a way that can be understood by people who can't see where I'm pointing. So first of all, let's talk about the population of people that we used to get this data. So these were people in a group PTM study, it was a study where we were providing progressive tinnitus management. And progressive tinnitus management is basically teaching coping skills to people who are bothered by their tinnitus to improve quality of life. And the skills are taught by both mental health people and audiologists. And this particular study was one that was conducted in 2 VA clinics. So researchers taught VA clinicians how to provide the intervention, and then the clinicians provided it.
Could you ask them to mute their microphone?
We're hearing some kind of noise from one of the sites, so if you could press the mute button at the remote sites, that would be helpful. All right, so this data is collected, so researchers taught clinicians how to provide progressive tinnitus management. Oh, now we're hearing hold. We're gonna get it.
That's tinnitus.
All right. So clinicians were taught how to provide the intervention, and then they provided the intervention to their regular VA clinical patients. And these people all received all of the hearing care they needed before they started the intervention. So nobody got hearing aids during the intervention, and they, for the most part, all had hearing aids if they needed them. And there was no minimum requirement for tinnitus severity. So these people, if they're interested in learning coping skills for tinnitus, they could come in. So let's take a look at the graph. Let's start out looking at the vertical axis where it says change in TFI score. So if you look at the 0 on the change in TFI score, that means, so we measured the TFI at baseline and six months later. And this is the change. So if you look at the 0, that means at baseline they had exactly the same score as they did 6 months later, and the black horizontal line that goes across the graph reflects no change on the TFI. If the number is positive, if it goes up into the 20, 30, 40, that means that they're more bothered by their tinnitus, they're doing worse than they were before. And if the score goes down, that means they're less bothered than they were before. And now let's look at the bottom, the horizontal axis on the bottom where it says my tinnitus now bothers me. So this is where we're looking at subjective reports of do I feel like I'm doing better than I did before. So let's start out looking at the middle. There's my tinnitus now bothers me the same. And so this question was asked at the 6-month point after everything was done, and everybody who said they were doing the same as they did before the study shows up in kind of this wide blue bar in the middle. And you can see above the word the same, it says 30. That's the number of people who said they were doing the same. There were 34 people who said they did a little bit, their tinnitus bothers them a little bit less, 14 who said their tinnitus bothers them somewhat less, 14 says it's a lot less. And then if you're going in the opposite direction to the left, those people are saying they're now more bothered by their tinnitus than they were before. So next up, let's talk about these little colored diamonds. So let's go back to the middle, the yellow diamond. So this yellow diamond reflects the people who said, my tinnitus bothers me just as much now as it did before. And you can see the mean change on the TFI score for that yellow diamond is really close to 0. So if you're looking at averages for a group, the people who said I'm doing the same had almost no change on the TFI score. It went down a tiny bit, but not much. And then if you go over to the next green dot, these people are saying I'm a little less bothered by the tinnitus. The mean TFI score for those folks is lower than it is for the people who said the same. If you go in the opposite direction towards the orange, the people are saying my tinnitus now bothers me a little more. The mean TFI change score for them was going up. So overall, the pattern of the responses we got is really reassuring. So if you're looking at the mean for all of the people, in the study. Generally, the score on the TFI was going up, but people said they were doing worse, and it was going down if they said they were doing it better. And we've applied the same thing to multiple sets of data, and the angle, the slope isn't always the same, but we see the same pattern. This shows up pretty consistently, and it's really reassuring to us that this instrument is doing what we want it to do. And so next, let's take a look at these little blue marks that show up all over the graph. And these are individuals. So you can see, if you look in this blue section in the middle, all these little blue pluses are individuals. And you can see they said, I'm doing just the same with my tinnitus as I was before. And then you can see the full range of scores. So way on the bottom end, you can see there was somebody who had nearly a 40-point drop on their TFI. And they're saying, my tinnitus bothers me just as much as it did before. And way at the top, you can see that there are some people saying close to a 40 point increase in the TFI, which looks bad, saying I'm just the same as I was before. And the reason I'm pointing this out to you is because clinically, if you're collecting both the TFI and you're asking people for their subjective impression of change, you will see mismatches. That'll happen quite a lot. And that doesn't mean that the instrument's not working. It's just two different pieces of information. If you're thinking about an individual, I think it's really important actually to take both pieces of information into consideration. And you can trust that the instrument is still doing what it needs to do, particularly when you're looking at your group data. So we're going to take this one step further. So earlier, I was explaining when they were developing this instrument, they were trying to figure out how much of a change was meaningful. They looked at the mean change score for people who said, I'm doing the same, and then they looked at the mean score for people who said, I'm doing a little bit better, and they looked to see how much of a difference there was between the two. So it was very tempting for us to try to come up with our own standards, kind of like Starzinski did, but using different methods to figure out how much of a change would be meaningful for our population. And I'll show you the numbers we came up with. So if you look at the difference between the mean score for the people who said I'm doing the same, and the mean score for the people who said my tinnitus bothers me a little bit less, it's about a 5-point difference. And if you look at the difference between the same and somewhat less, it's about a 4.1-point difference. And the reason these numbers exist is because we were very tempted to come up with our own standards. And ultimately, when we published this data and when we published other data, we did never include it. Mostly because very wise statisticians were discouraging us from doing that. They really encouraged us to stick with the original standards that were developed as part of the instrument and intended to apply to anybody that you use the instrument on. And I'm sort of pointing this out to you just because you are going to see differences with your population, the population you're serving, and what you're reading in the literature. And again, it doesn't mean it's wrong, but you really need to continue paying attention to the standards that are out there. It's okay. I don't think it's bad to use this to kind of inform your own impressions about what's happening with the people you have. But I think if you want to dive into this world, I think you need to work with really knowledgeable statisticians who can help you understand the limits of what you're doing. So I've mentioned a couple times, or at least once, paying attention to, so if you're providing an evidence-based intervention, I think it's really important for you to compare your results using the same instrument to what shows up in the literature, and also to your peers and to yourself over time. I'm showing you this graph really to encourage you to be really careful about. If you're comparing yourself to what's in literature, you have to be really careful about who in the literature you're comparing yourself to. So this is the outcomes for a whole bunch of different studies. I really want you to pay attention to this mean TFI change clear over here on the right. You can see that for one study, the mean TFI change was minus 5.7, so the mean score went down by about 5.7. And for this group down here, it went down by nearly 29 points. So there are important details you need to pay attention to. So for example, on the very top one, group PTM, that had kind of the smallest change, with this particular study, anybody was allowed to come in, so they didn't have to have a particularly big problem with tinnitus before they came into the study. Anybody could come in if they wanted to learn coping skills. And also these people didn't receive hearing aids, so we know that didn't influence their outcomes. If you look at this bottom one where people were given hearing aids, that's the biggest change score. It's nearly a 29-point drop. And it's important to know that these people all coming into the study needed hearing aids that did not have them, and they were given hearing aids as part of the study. So we don't know how much of that shift is because of hearing problems improving and that showing up on the outcomes instrument being used for tinnitus. So this is a really important thing to pay attention to when you're interpreting your own outcomes. did the people get hearing aids while they were during the intervention period? Tele-PTM up here, so the top two, the intervention was the same. It was teaching coping skills, and in both cases, nobody was given hearing aids. But there's a big difference between the scores. And so one difference that people pick up on pretty quickly is that the intervention was provided to a group versus individuals. That probably did play into it. But there are other important details, like for this tele-PTM study with the minus 20.9 drop, those folks had to have pretty severe tinnitus before they were allowed into the study. So that probably had an influence on the kinds of outcomes we saw. Also with this one-on-one, the intervention was being provided by experts whose entire careers are focused on tinnitus, and in the other one, it was being provided by clinicians who recently been trained to provide care for tinnitus. So I do want you comparing yourself to literature, and also you have to pay really close attention to the details about who you're comparing yourself to. All that matters. So I'm just going to kind of, the rest of the talk is really going to be sort of a review or talking about just basic guidance on how to think, on ways to think about looking at outcomes for individuals and ways to think of looking at outcomes for groups. So we already know there are no limits to any statistically validated outcomes instrument like the TFI. And we know that there are going to be mismatches between asking, do you think you're doing better, and what shows up on the TFI. And I think it's really important, particularly when you're working with an individual, to take both of those into consideration. You really don't want to be assuming the meaning of a change in a TFI score for an individual that the person isn't experiencing. Occasionally, I hear people kind of being tempted to point out to a patient that, oh, if they're saying they aren't doing any better than they were before, to say, oh, but look, your point is your questionnaire has dropped by this many points. And I think I discourage people from doing that. I really think you need to pay very close attention to the subjective report. Do people feel like they're doing better or not? You can talk about the score on the instrument, but it's my opinion is that a big part of the care we provide and why we're successful is because of the relationship between provider and the patient. And so if you're telling somebody who says, I'm not doing any better, if you're saying, yeah, actually you are doing better, that could do some damage to the relationship. It could lower your trust. It could reduce their willingness to continue engaging with you. So it's something that has to be handled really carefully. When you're looking at individual, in fact, I really think the TFI outcomes are most useful for looking at groups, for kind of assessing your own program and are you satisfied with how effective your program is in general. It can be used with instruments, with individuals, but I think it has to be handled very carefully. And I would not contradict what a patient tells you about whether or not they're doing better. Outcome data for groups. So I think the outcome data for groups is really important programmatic information. You know, something we know is that when evidence-based practices are implemented in a clinic, they're almost always changed. It's really rare for an evidence-based practice to not be changed in a clinical setting. And for that reason, I think it's really, really important for you to be keeping track of your data for groups, looking at just the mean changes on your outcomes instrument for a group. That'll tell you that can inform you if the modifications you made were problematic. That could be the cause. It can really get you paying attention to what needs to change about your program. And for people who are in the VA or DoD using outcomes instruments and keeping track of what's happening for your population as a whole is a tremendous opportunity when you're in a clinical community like the VA and DoD. Everybody in the VA and DoD is part of a huge community serving a similar population. We've got I know everybody says once you know one VA, you know one VA, but it's also true that we're all navigating the same system and our patient populations are pretty similar. So if you're not satisfied with your outcome, you can call on your community for assistance. And if you're satisfied with your outcomes, you can make yourself available as a resource to other clinicians who are providing the intervention. And I've seen both of those things happen within the VA system. And I get very excited when I see those things happening within the VA system. And maybe you'll discover that you're a shining star. There was one particular VA clinic. I didn't ask for their permission to talk about them, so I won't say who they are, but they implemented progressive tinnitus management, And they made some pretty big modifications to it. They took out a big piece of the mental health portion. They left most of it there, but they took out one big chunk of it, and they added something that's typically not part of PTM. Had to do with teaching strategies for dealing with hearing loss, because that was coming up with almost everybody. And they got really spectacular outcomes. The mean change on their TFI score, I don't remember the number, but it's some of the best numbers I've ever seen. They're really good. So we helped that group actually publish the results of their findings and describe what they did, which I think is a really important and lovely way for clinicians and the research community to start interacting. Something else I'm going to mention is that it's not here yet, but there's a database coming, a nationwide database for tinnitus outcomes coming, where you'll be able to put your data, and I think that will increase the opportunity for clinicians to interact with each other and learn from each other about how this works in a clinic and what works well in a clinic and what doesn't work so well in a clinic setting. I'm very excited about that. I want to talk a little bit about how to use the 13-point estimation provided by the developers of the TFI. So I'm actually going to start out telling you what not to do. So it's really common for people to want to look at the mean change for a group on the TFI score and see that it's not 13 and think, oh, is this a meaningful change? And this is something even reviewers have asked us about when we're submitting papers for submission, and we've had to explain to reviewers that that 13-point estimation only applies to an individual. It really cannot be used when you're looking at mean changes for a population. So, I mean, I would almost go as far as to say it's irrelevant when you're looking at the mean change of a population. You're not aiming for 13. If a mean change is less than 13, that doesn't mean you didn't do anything meaningful. One thing you can do, and we do this whenever we're publishing the results of our work, is pay attention to the percentage of your patients who had a 13-point drop on the TFI or greater. So that's a really helpful thing to do, and a helpful thing to report, and I think it's a good benchmark to pay attention to. And all along, I mean, keep your mind locked onto the fact that that 13-point is an estimation of meaning. It really does have limitations. We will never know exactly how much is meaningful for a person. All right, so how to use TFI data for quality improvements. And I've already talked about this a little bit. Just compare your results to what shows up in the literature, but pay really close attention to the similarities and differences between the research population and your population. That matters a lot. Calculate the percentage of your patients who had a 13-point drop or greater on the TFI and compare that to your peers. And use this information to drive your quality improvement efforts. How to use subjective impressions of change. I think it's really important to ask for subjective impressions of change and use that when you're interpreting how an individual is doing. I really think that's more important than what shows up on the TFI for an individual. I do think it's good to also calculate the percentage of your patients who reported improvement. So we do this too. We figure out how many of our patients had a 13-point drop on the TFI or greater, and we also calculate what percentage of our patients said they're doing better. And then I've just got sort of a word of caution. It's not necessary or expected to try to come up with your own guidelines for how much is a meaningful change. If you want to do that, you really need to work directly and closely with a statistician. And we've got a lot of time for questions.
Just anecdotally, how do you encourage people who come into a PTM group to seek hearing care without alienating them or making them feel like, oh, I have to go through this step first before I participate in this group? Since you had such a dramatic outcome with just fitting with hearing aids, how do you stress that without making it another hoop to jump through?
So I don't know how good these microphones work. And Dan's work was just asking anecdotally, how do you deal with making sure people's hearing needs are taken care of before they come into the group setting? And how do you make that not feel like an obstacle to getting in? And really, most of what I have to offer about that is I haven't heard clinicians saying that feels like a big obstacle to getting people in groups. From a research perspective, when we're doing a study where we're teaching coping skills, we require people to get their hearing needs taken care of before they come in. And usually people are willing to do that. In the VA setting, in the civilian world, it's much harder because, so in the VA system, it costs little to nothing for veterans to get hearing aids, and then in the civilian world, some people genuinely can't afford to do that. So it's, and my personal opinion on all of that is, if somebody's interested in teaching, learning coping skills for tinnitus, get the hearing aids needs taken care of as well as humanly possible. And sometimes somebody isn't willing or able to get hearing aids, and then just teach them coping skills anyway.
How is the tinnitus functional index different from the subjective response? Does it quantify the loudness of the tinnitus?
Oh, so she's asking what's the difference between the subjective impressions of improvement and what's on the TFI. I think the TFI does have one question on there where it asks people to rate the loudness, but it's really focused on how is tinnitus impacting function. So it's getting at, is it impacting your ability to sleep well? Is it impacting your ability to concentrate on things? There are 8 domains and I don't know what they are, but it's really focused on the functional effect of tinnitus on your life. And the subjective one is just, do I feel like I'm doing better than I was before?
So the reason I ask is because if the tinnitus bothers you less, maybe some people are very sensitive, so even a small amount of very quiet tinnitus bothers them just as much as a loud tinnitus. So they might not show much improvement subjectively, but
Yes.
that might explain the difference between the two. But maybe if it's functional, it might not be that much difference.
So I think you're wondering about the interplay between changes in what tinnitus sounds like and what shows up on the TFI and what shows up on the subjective impressions. Well, first I want to say that the TFI and these subjective impressions of change can be used for any intervention. It doesn't have to be PTM. It applies to anything. And everything I've talked about applies to any intervention. My world is pretty PTM centric. My world is pretty focused on coping skills. So we're generally not even asking people intentionally, unless it's part of a pre-made questionnaire, if the loudness of their tinnitus has changed. We're not trying to change the loudness of it, and we're not asking about it. So our subjective question specifically says, are you bothered more or less by your tinnitus? And we kind of don't care if the loudness has changed if we're studying PTM. That's not the case with everything else. And this functional index is really also mostly focused on function. So from my perspective, when I'm focusing on coping skills, I'm really trying to get people to tell me, just, do you feel better than you did before? And are you functioning better than you did before? And if their tinnitus happens to be, I don't think anything we do is changing the loudness of tinnitus. If you're applying these instruments to like a device where they're intending to change the loudness of tinnitus, it's similar with the subjective change. If people feel like they're doing better, they say, I'm doing better, my tinnitus bothers me less than it did before. Because there's no objective way to measure tinnitus, we don't really know if that's because the tinnitus got quieter or if it's because they had a lot of attention from somebody who was knowledgeable and caring. And the same with the functional index. That's a lot of that is getting at impacting your quality of life, and if your quality of life is improving, we don't really know if it's because the tinnitus got quieter or for some other reason. So that's the whole world of tinnitus is kind of the fact that we have no way of objectively knowing what tinnitus sounds like or how loud it is has caused me to focus more on, is it bothering you and how are you functioning? Other people do put lots of attempts to quantify loudness, and I'm less qualified to speak about that.
So you describe hearing aid use as a confound for assessing how well a particular tinnitus management technique works. And I was just wondering if people believe that hearing aid use really is a confound only, or if there's some thought that maybe hearing aid use actually does affect the generation of tinnitus.
Yeah, so you're asking about the ways in which hearing aid use is a confounding factor when you're looking at outcomes, and maybe outcomes look better because you're changing something about the generation of tinnitus. Maybe. I don't really know. It's, you know, it's when it gets to loudness, because we don't have an objective way to measure it, we don't really know if it's changing. My experience has been what people with tinnitus tell me after they get hearing aids. They usually say that the tinnitus sounds louder while the hearing aid is in, and when they take it out, they say one of two things usually. Either it's louder than it was before, and we don't know if it's really louder, if it just seems louder because they've had hearing aids on all day, or they say it's no different when they're off. So it's certainly not common for people to report that when they take hearing aids out, their tinnitus is quieter than it was before, and sometimes people are hoping for that and are disappointed by it. So I don't think that's what's happening, but I don't know. And if you look all of the validated outcomes instruments that exist out there, if you look at them through the lens of, could somebody be telling me about their hearing problem instead of about their tinnitus when they're answering this question? There are a bunch of them in every outcomes instrument that exists. Which, with interpretation, you just have to keep that in mind when you're interpreting outcomes. If it's a big change, and they also, some or all people also got hearing aids during that period, you don't know if it's because they're doing better with hearing or if it's more about the tinnitus. And it's also true that people do say their tinnitus sounds quieter when they've got hearing aids in, so that probably has some kind of effect too.
I was also wondering, thank you, that was great discussion. Can you tell me a little bit more about this database that's being developed, the nationwide database that's being developed for tracking tinnitus management effects? What's happening?
I don't know that I can tell you a lot about it. I mean, we're working with central office to get that up and running, and it'll be our crew here managing that. We don't know exactly what it will look like, but the folks in central office agree that it's a really big deal to track outcomes. Central office wants to see clinicians tracking outcomes. We want to see clinicians tracking outcomes, and we're really excited about partnering with central office to give that a home. Well, I'll just say to give it a home. I mean, in dreamland, where we have all the time in the world we would like to help people interpret them too, but I won't promise that.
Are they paying for it? Are you paying for it? Who's paying for it?
There's no money being exchanged for that. There are a lot of dedicated and passionate people, passionate and compassionate people involved, but nobody's paying us to do that.
I have a question about that figure that you had, the TFI change versus subjective report.
Yeah.
Quite a bit of them, and especially the one that showed the same.
Yeah.
You have this huge range of responses on the TFI.
Mm-hmm.
Do you care? And that's question number one. And number two is, how do you account for that? And why, I guess, would somebody who says nothing's changed give you a score that's 40 higher on TFI, and another person give you a score that's 40 lower on TFI when they both perceive no change?
Yeah. So he's asking, if you look at this same bar with the yellow diamond, he's noticing that there's really a huge range of scores there, and kind of asking, why is that happening, and how do you account for that? What do you do with that? I think there are about 1 million reasons that could happen. So one piece of it could be that, with the subjective question, we're just asking one time on one day, are you doing is your tinnitus bothering you the same, more or less than before? And they give us an answer. With the TFI, the instructions say to fill out all of the responses based on how they've been doing, is it the last 1 week?
Last week.
Over the last week. So it's possible that the day we did the baseline, they were having a really bad day, and that's really what was, either bad day in terms of their tinnitus was loud, or bad day in terms of something terrible happened, or they got some kind of, there are lots of reasons that people could be having a really bad day and could really truthfully fill out the instrument so that it looks really high, even if 2 weeks later it wouldn't look like that for reasons that aren't really about tinnitus. And the same thing for the follow-up. They're asked to fill out that response option for what happened over the last week. And I've had people tell me, like, oh, my wife was diagnosed with cancer the week I filled out that questionnaire. That was a terrible week. Like, that's not representative of what usually happens, but we kind of have to go with it because we're researching and we follow procedures. So I think that's one reason that can happen. Do you have any other speculation, Emily, on why that Emily is a statistician with us, and she speculates with us a lot about why our data looks the way it does.
Sometimes I wonder if the the tinnitus now bothers me, the same response might come a little bit from people wanting it to sound different also. And they
Yeah.
might say, well, it sounds just the same as before, so I'll say the same, even though the question asks about how much it bothers them. And so that's my guess as to why we see a really big improvement on TFI that's asking about how much are you able to sleep, how much are you able to concentrate, and they're saying that they're doing better, but then they might say, but my tinnitus is still the same, so they circle the same.
Yeah, that's a really good point. So when we're teaching coping skills, we're always telling people up front, we have no reason to believe your tinnitus is going to change as a result of what we're doing. We're just teaching you how to manage the emotions around it, and they seem to understand it. They can say it back to us, and then when we're talking to them at the end of the study, they're like, I am so disappointed that my tinnitus sounds just the same as it did before. So I do think that can play into this subjective report of am I doing better or not. Because people, even though they understand it intellectually going into it, sometimes they're still disappointed that their tinnitus didn't change.
They're saying that they may be asking a different question, or it may be interpreted differently than intended.
Yeah,
There's
and,
always room
I mean,
for
we
that.
have multiple meetings about how and where and why to ask questions to try to get at what we're getting at, but humans are humans, and sometimes other things slip in there.
Thank you.
Yeah, so that's part of it. And then in terms of accounting for it, this is part of why I think I put more, I give more weight to looking at mean scores, change scores for a group than I do looking at individual scores for the TFI. It's so common to have mismatches between the two that I tend to believe what people are telling me about whether or not they're doing better if I'm just looking at an individual. But if you're looking at something programmatically, just the slope of this is really consistent. It almost always lines up. I mean, sometimes it's a steeper angle and sometimes it's a shallower angle, but with groups, we really do see a nice connection between the mean change scores on the TFI for people who are saying they're worse, better, or the same. So that's kind of how we account for it. I don't put too much weight in an individual TFI score.
Recently, I participated in a tinnitus pilot that circulated through the VA on progressive tinnitus management. And as part of the series of modules, 2 questionnaires were discussed. I don't recall their names, but one questionnaire separating hearing loss from tinnitus and another questionnaire quantifying the effects of intervention. And I don't believe that either one of those questionnaires were the TFI. So if you know what I'm talking about, why are you choosing to talk about the TFI today and not the other 2 questionnaires that were included in the modules on PTM?
Okay, so to repeat your question, she's been doing some online training modules for progressive tinnitus management, and there were 2 questionnaires in there. One was designed to separate hearing stuff from tinnitus stuff. I do know what you're talking about. That's called the Tinnitus and Hearing Survey.
Mm-hmm.
And then she said there's another instrument that was used that she didn't think was a TFI. I would be willing to bet my car that the other one was a TFI, but I might be wrong. I know the people. Oh, I'm sorry. I'm not sure how that's going over with you. The people who develop those modules are also part of the people who develop the TFI, so I would be surprised if the TFI isn't the one in there. Before the TFI existed, we used to talk about using the THI, the Tinnitus Handicap Inventory, and really in terms of statistically validated outcomes instrument, the TFI, it's my favorite one. It was the first one that was developed specifically to be sensitive to change as a result of intervention. And when I look at the procedures they used and the care they took, I'm really impressed. It stands out as compared to the other ones. They were so careful about having a huge population of people getting care in different parts of the country from different clinics with varying degrees of a problem. And I haven't seen that kind of thorough development with other outcomes instruments. So that's why I recommend this one. And I would be surprised if that's not what's in the modules, but this isn't the only one. I mean, the THI is fine, the TQ is fine. There are a handful of outcomes instruments for tinnitus, and as long as you're using one that's statistically validated, it's okay. It's an okay way to go. It's if you're wanting to compare yourself to what's in the literature, a lot of the more recent literature has the TFI. But you could even choose your instrument based on what you want to compare yourself to. So it's this. I like this one a lot, but it's not the only right answer. And then in the modules, there's a statistically validated instrument in there. And the other one was the THS, which is the Tinnitus and Hearing Survey. And then just a couple quick words on the difference between those two. The THS is really designed to separate hearing stuff from tinnitus stuff, so the person you're working with is the clinician and the patient are talking about the same thing. So you can point to the hearing section and say, do you want to work on this? Or you can point to the tinnitus section, which is carefully designed to not be influenced by hearing, and say, do you want to learn coping skills for helping with sleep? Is that what you're interested in? Or do you want to figure out how to understand your grandkids better? So just is a way to clarify the difference between the two. And the THS has not been statistically validated for use as an outcomes instrument. I am told that clinicians informally are using it like an outcomes instrument because it's short and easy to use. Our research group is looking into validating it as an outcomes instrument, but it's not there yet. So I still wouldn't recommend that for outcomes, but it's great for having really clear conversations about what people want to work on. And then the outcomes instrument, this is my favorite, but there are other good ones out there.
Is there any structure to the item responses that lead to the change in the TFI score? In other words, are some items more likely to show a change, others less, and does that change with the type of intervention?
I don't know, really. So he's asking if certain items are more likely to change, and if there are items showing up on the TFI, does that influence the intervention provided?
No.
Oh.
So if you engage in one type of intervention or another one, are there groups of items that are more likely to be altered?
Maybe, but I don't know. I mean, like one of the functional domains in the TFI is sleep, and there are some interventions for tinnitus that are more focused on sleep. So maybe, but I haven't looked at. I don't have much experience actually at all. Pulling out the different domains or questions and seeing if some of those are more likely to respond to a particular kind of treatment. It could be, but I don't know.
At least in terms of the auditory domain, we did see a difference when looking at the studies that didn't try to give any treatment for hearing during the study, and the studies that included getting a hearing aid as part of the treatment. The auditory domain would change a lot more, improve a lot more if they got hearing aids. And I compared to the other domains, and then for the studies that made the hearing aids part of the pre-study, that domain didn't change as much as the other domains. So at least as far as that particular domain, I remember seeing a difference concerning the type of intervention.
I'm gonna summarize that because I'm closer to the microphone than you are. So Emily is pointing out that on the TFI there's an auditory domain, and she has seen if somebody's getting hearing aids as part of an intervention, more of a change on the auditory domain of the TFI, and for people who aren't getting hearing aids, seeing less of a change on the auditory domain of the TFI. And actually the auditory domain on the TFI is something that comes up if you dig deep into the literature and start paying attention to people's opinions about the TFI and various domains. The auditory domain of the TFI does seem to stand out as being kind of a different animal than the other domains, which isn't terribly surprising to me because hearing is kind of a different domain than tinnitus. There's even a group in the UK who thinks that the auditory domain shouldn't be included when you're doing the TFI. I don't know if I agree with them on that, but that's their opinion. And I understand why they're saying it, because it does show up as a different animal than all the other domains, and it makes sense that would.
Regarding differences in domains between TFI and THI, I believe one of them is designed not to have catastrophic thinking questioned. Is that? And I don't know if that's important for using it in clinical research, if that's going to affect your outcome, whether including questions that refer to catastrophic thinking would influence how they're responding at all.
So I've got thin memories that I don't completely trust. I do believe that THI has some things that are specifically trying to get at is catastrophic thinking happening. I think you're asking, do people sometimes react differently to questions about catastrophic thinking than they do an outcomes instrument that doesn't have catastrophic thinking on it? Is that what you're asking?
Yes, yeah, if it's included.
Yeah, so, you know, before the TFI existed, we usually used the THI that has the questions about catastrophic thinking. I don't remember people reacting badly to that. Some people commented on it because one or two of them seemed kind of dramatic and to people, and they would sort of point that out, like, "Oh, I wouldn't. It's not like that." I didn't feel like it got in the way of measuring what we needed to measure, but occasionally people commented on that.
Just to take that to a broader topic for a minute, both the TFI and the THI, you can talk about a total score, or we can talk about these subscales, which is sort of where this conversation's gone.
Mm-hmm.
And what you're asking in terms of if you have a questionnaire that includes catastrophic questions or not, one thing to think about is there's a strong correlation between the total score on the THI and the TFI. So in terms of not including it on the TFI, you still see this relationship between the two. So I don't think from just the total score perspective, that's going to drastically change it to answer your question. You're going to see improvement on both.
Yeah, in terms of measurement, do we see difference in outcomes because we're not including catastrophic thinking? Yeah, that's a good point. We have done plenty of studies where we've collected both the TFI and the THI. We don't do that anymore, but we did that for a while, and they did seem very well connected. We didn't feel like there was something missing.
Can you give me an example of catastrophic thinking? What is that?
My life is going to be over. I can't cope at all.
That's pretty catastrophic.
Yeah.
Okay.
So what Sarah said, I could hear you when you were pointing towards me, was my life will be over. I can't cope. So that's yeah, catastrophic and like catastrophic type thinking. You asked for an example, and Sarah gave you one, and I didn't. That's we're gonna go on that.
On the THI, there's one that says, I feel like I have a terrible disease. I feel like because of my tinnitus, I feel hopeless. Things like that are just very dramatic, kind of. And you say yes sometimes or never.
Yeah, that's great. I think you're giving us examples of the catastrophic domain. Right. What'd you say? Might feel like my life is over?
No, it was me.
Oh yeah.
Yeah.
Because of your tinnitus, do you feel like you have a terrible disease?
Oh, yeah,
Because of your tinnitus, do you feel hopeless?
Yeah, because of your tinnitus, do you feel like you have a terrible disease, or because of your tinnitus, do you feel like you're hopeless? Yeah. I'm partially that because I'm
And it's not
yes,
catastrophic.
thank you, both of you, for giving us examples of the catastrophic stuff.
Catastrophe.
Yeah. Any other questions? All right. Dylan?
No, just going back to the subscales, there was some questions about other domains. With studies that you haven't talked about, there has been information in the literature that's looking at characteristics. So the subscale on sleep we've seen also indicating different things. So depending on what your research question is, looking at the subscales can be helpful. And I guess I'm just giving a plug for the TFI to realize that even though auditory is one that we've been talking about today, the other subscales that I find can be really informative deal with the sense of control and sleep.
Okay, so I've spent almost no time paying attention to the subscales. So sense of control and sleep, those things that kind of stand out for you?
But I think back to the question of what was the study designed to do? And are we talking about it in terms of a clinical question or a research question? And so I've seen the literature address that and look at it, but I really advocate for the kinds of things that we're talking about right now, total score, I think is going to be more predictive and indicative of what's going on. But the subscales can be very informative and help with other questions.
Yeah, great. Any other questions or comments? All right, thank you, everyone.